acute congestion. I will talk only about heart failure. I'm from Göttingen University, and I will start with this statistic data. This is from the US. 1 out of 4 people will have a risk for heart failure in his life. And I think this is a very big number, and so we have to deal with heart failure. When I was in Madrid this year, John Cleland, he's from the UK, he talked about heart failure and about congestion. You have always to think what is the reason for breathlessness or edema, and you have to ask for the prognosis and for the management of these patients. And he told that there will be a new universal definition of heart failure in next time, I think next year. And you can see here in the middle that heart failure is cardiac dysfunction and congestion. And I very seldom saw people with advanced heart failure without any congestion. So it's very nice connected together. In these patients, and you have always to think about congestion in heart failure patients, there's no problem to see that they have a volume overload. But I think that Wolfgang Feske will tell us more about diagnosing the hypervolemia. And it's not only important to see whether there's edema or pleural effusion or ascites, but also to grade this, for the grading makes an impact on the prognosis of the patient. What do the guidelines tell us? You see here the heart failure guidelines for HFrEF, and I marked it with red that in volume overload you have to give the diuretics. It's for avoiding heart failure hospitalizations, avoiding mortality, but it's also for symptoms and to improve exercise capacity. And you can see that also for heart failure with micro-reduced ejection fraction and preserved ejection fraction, the volume overload can be handled with diuretics. This was the first that I found about diuretics in acute decompensated heart failure. It's Michael Felker. He published this in 2011, and he compared a bolus and a continuous infusion and a low dose and a high dose strategy. And you can see that there is no statistical difference. There is some difference comparing the low dose and the high dose in getting rid of the volume, and there is no statistical significance concerning the change in serum creatinine. Then we can mention the dose trial. It's from 2012, and they also compared doses and a continuous infusion, and they doubled the home doses of the loop diuretics, but they could say that it's very important to look at the dose that the patients have when they enter the hospital at home. And with this dose being above 120 milligrams, then it's very important. These patients have a worse prognosis compared with those who have only a small furosemide doses. And so the AHA guidelines say, please take 2.5 times the chronic daily oral dose to give it then routinely as an infusion, continuously or by bolus. And the American guidelines say there is the diuretics after discharge have to be continued You have not to stop the diuretics when discharging a patient for giving the diuretics. This will prevent readmissions. But again, John Cleland, he had a trial in the United Kingdom, in Scotland, and there was about 200,000 patients, and you can see here they are with heart failure and with loop diuretics, and they have a very worse prognosis. But if they have no heart failure but diuretic therapy, their prognosis is also bad. So please always check what is the reason for the diuretic therapy. And it's not only the loop diuretics, but also other diuretics, the acetozolamide, the SGLT2 inhibitors, the loop diuretics, the thiazides, and the mineralocorticoid receptor antagonists. The mineralocorticoid receptor antagonists are one of the 4 columns in HFrEF, so I will not discuss them. But of the others, there is some data. There are trials, ADVOR, Chlorotic, and Transform, that the ESC update for the heart failure guidelines recommended to read. In the ADVOR trial, acetazolamide was given in addition to a loop diuretics in acute heart failure. And you can see that the volume is more rapid put out of the patients, and that more patients are decongested at their discharge. Chlorotic was the same, loop diuretics, and in addition, hydrochlorothiazide. And this is the same. You can have more volume out of the patients in a smaller time amount. And Transform surprised many of us, for it compared torsemide and furosemide. And please look at the data for all-cause mortality. About 1/4 of the patients we discharge will die in the next year. So it's very important to look at these patients. And now the data, we thought torsemide would do better, but you can see here they do the same. We have not only to look at the drugs, we also have at the diuretic therapy, not only looking at the volume, at the urine volume, but also at the urine sodium. For when you take out the sodium of the body of the patient, then it will be better for him with the heart failure. The PUSH trial in acute heart failure could tell us that compared with standard of care, it was better for the patients. And if we talk about drugs, we also have to take about the fluid that the patients intakes. There was a trial with liberal fluid intake versus fluid restriction. There were 500 patients, and it was published in Nature Medicine this year, and you can see it's better to have no strength fluid restriction. Concerning the quality of life, it's better to give the patient somewhat more fluid, but if you look at the amount, it's 1.8 liters versus 1.5 liters, meaning that one big glass of water decides about prognosis and about quality of life. Fine arts, finerenone is another player in our medical suitcase. It was given in ejection fraction with multi-reduced or with preserved ejection fraction. It's a mineralocorticoid receptor antagonist, and it was better concerning death and heart failure hospitalizations. And so the guidelines recommend to give it in type 2 diabetes and chronic kidney disease to reduce the risk of heart failure hospitalizations. This year there's a new trial with finerenone the confidence trial. This is finerenone versus empagliflozin versus the combination. And the combination is better than every single of these substances. So I think we have to combine this. Let us have a look at the SGLT2 inhibitors in acute heart failure. You know the results of the EMPULSE trial. Empagliflozin was better than placebo in these patients. And this year on the ESC conference, the dapagliflozin trial was published, DAPA ACT HF TIMI 68. And you can see that there is a difference after 2 months, but that was not statistically different. So they made a meta-analysis with SGLT2 inhibitors in acute heart failure, and SGLT2 is better than placebo for these patients. The SGLT2 inhibitors have many pleiotropic effects. They do not only harmonize the serum glucose levels, there's a weight loss, but they have also antiarrhythmic properties. But in many patients, there is a decline in estimated glomerular filtration rate after the initiation of SGLT2 inhibitors. And there was a big editorial in circulation about this dip. And you have to stay in course with the SGLT2 inhibitors, for in the course of the disease, this will be better for the renal function of the patients. Full guideline-directed medical is the best to digest the patients. So we have to look at the other substances. There is a new substance. It's an old one, the digitoxin in patients with heart failure and reduced ejection fraction. And it comes from Germany. It was given in patients with ejection fraction below 40%, and it was better for death and for heart failure hospitalizations than placebo. And this means there is a new player. The vericiguat is an old one. You know it from the Victoria trial. In this Victoria trial, it was patients with worsening heart failure, and they got the vericiguat. And it was not different for death, but for heart failure hospitalizations. And so the guidelines tell us to give the substance for the patients in addition to the normal guideline-directed therapy if they come back to hospital. The Victoria trial gives this vericiguat now in patients with reduced ejection fraction, but stable conditions. They should not have any deterioration in the last month. And you see there is no effect on heart failure hospitalizations, but on a combined heart endpoint. And so there are many that tell us that in the next guidelines there will be not the fantastic four, as you know them, with the ACE inhibitors, the beta blockers, the mineralocorticoid receptor antagonists, and the SGLT2 inhibitors, but with vericiguat, we don't know. Maybe it's with digitoxin. So let me summarize with this slide. In the management of worsening heart failure, you give the intravenous loop diuretics. You have to initiate or continue the SGLT2 inhibitors. You may give the acetazolamide and the thiazide. And you have to have some rescue therapies, maybe ultrafiltration or things like that. Why is this so important? The cause of heart failure in patients is deterioration, and then they will have a phase of advanced heart failure. And in this golden window of referral, you have to recognize the patients and then send them to a center so that they can look for advanced heart failure therapies like heart transplantation or assist device implantation. So thank you for your attention, and if there are any questions, I will be glad to answer them.
Thank you very much, Birgit, for this very interesting talk. There are any questions about this lecture from the audience? So maybe I have a question about the SGLT, the pleiotropic effect of the SGLT2 inhibitors. Can you tell us the side effects of these substances?
Yeah.
It's not too less, I think. Yeah?
There are side effects, and the most important in clinical daily work is the urinary infections. For there's glucose in the urine, and this may produce infections. But there is some data from the US, and they tell us if there is one infection, please, in patients with very big problems with heart failure, try to continue it with hygiene measurements.
Okay. No antibiotics.
You have to.
Okay. So.
If there is an infection and the patient has problems, then I would give him antibiotics, and I would stop it for about 3 days. Okay. There is a sick rule day for the SGLT2 inhibitors. This means that when the patient is in hospital, when there is an operation or things like that, he has fever and he is not eating very well, then he should stop the medications. But he should not stop it for a longer time or terminate it.
Oh, that's a very important answer. Okay, there are other questions, comments? So we should go.
Thank you very much, Birgit, for the